Well, I'm going to go ahead and kick us off because we have some people on the Zoom line as well. So for those of you that don't know, my name is Michelle Barnes, and I'm the chair of the Behavioral Health Task Force that was initiated by Governor Polis in response to a lot of people in the community saying they wanted a better behavioral health system. And we're looking at it from kind of the big picture. We're looking at mental health as well as substance disorders. So this task force has 1 year to quickly put some recommendations together and a roadmap to get us to a better system. So it's very quick timing. We have about 100 people throughout the state who have graciously volunteered an immense amount of time to serve on these task force and to help make the recommendations and the decisions. One of the things we're doing is going out around the state and listening to people's stories. So that's what we're here in Grand Junction to do today. We want to hear people's testimony. We want to hear from your words how the system's working for you. We're open to any ideas you might have, any best practices, anything you want to share. And the reason is we know that every part of the state's a little bit different and everybody's story is unique. And so we want to give an opportunity to give voice to that. The reason why there's people on Zoom listening, the reason why there's people in the room, and for those of you on Zoom, we do have a crowd gathering in the room, is we think it's really important that people's stories are heard and internalized. So when we're going and putting recommendations together and looking at legislation and looking at budget shifts and looking at process shifts, different ways of doing things, we're really holding true the stories of what the system's like from people that are part of the system or have lived experience or have a loved one in it or a provider. And so we really want to make sure that we're witness to these stories and that we amplify what you're telling us. So one of the things we're doing today is recording these. If you don't want your testimony recorded, that's absolutely fine. We can turn it off and it'll just stop with the people on Zoom and the people in the room. If you're willing to let us record it, we will put it on our website so more people in Colorado can see it, including everybody on the task force. We're asking them to listen to all the stories. We already have about 70 on our website. What we're doing is going out to a different community every month. This week's a little extra. We're in Grand Junction. Tomorrow we're going to be at the Public Health Building in Denver. So we've been to Durango, Douglas County, Denver, Grand Junction. We have a listening session next month at Tuac down at the Ute Nut and Ute Tribe. So we are trying to get out and hear people's diverse stories. So with that, just a few logistics. If you are here to speak, if you can sign in, and if you're willing to let us record, there's a waiver that you can sign right there in the third row. If you're on Zoom and you're speaking, Summer will help let you know when to speak up and moderate in that way. I do want to do quick introductions of people on the task force that are either on the Zoom or in the room. And I will tell you, we'll have people coming and going throughout. So this won't be all inclusive, but I'm Michelle Barnes, I'm the chair.
I'm Director of Ops Behavioral Health. Member of the task force.
Is anyone on Zoom that's on the task force?
And I would just encourage you, if you are participating by phone or on Zoom, please hit *6 to unmute yourself.
This is Eva Beach. I am on the phone and also on Zoom.
Great, Eva.
My name is Joyce Smith, and I'm also on Zoom.
Hey, Joyce Smith. Okay. All right. As I said, people will come and go throughout the next couple hours. Summer, do we have our first testimony is by Zoom? Are they on right now?
Let's see. So, hi everyone. We do have Debbie Channel, who is scheduled to testify first by Zoom. Debbie, if you are online or participating by phone, if you can hit *6 to unmute yourself and let us know that you're available, that would be great.
Can you hear me?
Yes, we can. Thank you.
Okay, I'm there.
Great. So Debbie, before you kick things off, I just for you and for everyone else, I want to thank everyone for taking the time to share your story with us today. We are asking people to limit testimonies to about 5 minutes each, give or take. When we start to go over time, if I need to, I'll gently jump in and give you a heads up that we're over time. But really, again, just appreciate you and everyone else being with us today. And with that, Debbie, I'll hand it over to you.
First, I'd like to know exactly what you would like me to talk to you about. Just our behavioral health shortage?
Well, this is really a chance for you to share your outlook and your point of view. So whatever you feel is most important for the task force to know about.
Okay. Well, our facility is located, we're the Spanish Peaks Regional Health Center, located in Walsenburg, Colorado. As some of you may or may not know, we lead the whole state in morbidity and mortality most of the time. We lead the state in child abuse per capita. We have one of the poorest counties in the state. And we also have one of the highest per capita ratios of opioid overdoses. So having said that, every one of those things, in my estimation, in my opinion, is that we need behavioral health. So what we have when we're dealing with poverty, chronic disease, drug abuse, alcohol abuse, we need some behavioral health help. Being located where we are, we're in a provider shortage area anyway. We're very limited to any kind of access to any kind of behavioral health that we have. We rely a lot on the one service that's here, but they primarily see Medicaid children. They will do adult emergency in the cases of maybe suicide attempts, things like that. So really, if we could just figure out how to get some behavioral health here. I understand, and we can access telemed to do some behavioral health, but we don't have the ability to get a lot of our people to an online service to be able to do telehealth with a mental health provider. So we're kind of in a catch-22. We just really can't seem to, well, one thing, because of our location, it's really hard to recruit behavioral health people. And our behavioral health issues in Huerfano County are just huge. So we're doing what we can as a facility. We're, trying to integrate some behavioral health into our clinics, but that's on a very, very limited basis, like 1 day a week. And we're part of the Colorado's Cure. So we're there. We are part of the Alto project. So we're trying to address a lot of our disparities, but it's difficult. So I'm open to anybody's suggestions at this point. And that's pretty much what we have going on in Huerfano County. We do have a very strong community coalition. We have a few of those. We have a Communities That Care that's just started up, so we're optimistic about that. Our health department has applied for some grants, but again, that doesn't really help our patients in the exam room when we could just do a nice warm handoff and maybe address some of these issues. We're trying to get people trained in diabetic education so we can address that health disparity. We're just really open to trying about anything. And that's where we are in Huerfano County.
Thanks, Debbie. Can I ask, are there things that you're hearing in other communities that you would like to see replicated in Huerfano County?
In this southeastern part of Colorado, I don't hear a whole lot of any best practice programs that are going on right now.
Got it. Thank you. Any questions from folks in the room?
Thank you, Debbie.
Thanks, Debbie, for letting us know more about what's going on in your county. We really appreciate it.
But it's one of the most beautiful counties in the state.
I've been there. I know. It is beautiful down there.
Oh, we have the best air quality, best water quality. Those things are wonderful. It's just we have no economic development, and I think that's probably our biggest prohibitor, other than marijuana. And we really like that business.
Great. Well, thanks, Debbie. Really appreciate you taking the time to talk with us today.
Thank you.
You're welcome. Next we have on our list Elizabeth Shear, if she's in the room. Do we want to check in on the room and see, since we are ahead of schedule, if there's anyone who did not sign up who's interested in testifying?
I'm here.
Great. Hi, Joyce. Thanks for joining us today.
Hi. I plan on calling in both calls because there's one tomorrow as well. I work on the front range in Lakewood, Arvada, and Denver. And I'm calling because I'm concerned about the rate decrease that CCHA has proposed to take effect in January. I assume that's hitting the whole state. It's going to require some of us to lay off counselors, which is going to reduce the number of clients that we can take. So I'm pretty concerned about the reductions that CCHA has just decided to make without anything but 2 months to just prepare for that. They're looking at a 20% reduction for people that aren't MDs. And my concern is that MDs are not doing this work anyway. So they're basically going to end up with a bunch of people untreated and nobody to do the work because they're not paying enough. Can people hear me?
You can.
Okay.
Yeah. Thanks, Joyce.
I can hear you.
If you could maybe be a little, I don't think most people know what you're talking about, what CCHA is. Could you just maybe talk a little bit more about what the issue is?
This is for the Anthem. The people that have Anthem have one of the rays in the Denver, North Jefferson County area. They sent all of the providers a letter that said they were reducing the fees by 20% unless you were a physician MD trained.
So it's a change in provider rates for Medicaid.
Yes. This does not appear to be a state mandated thing. This seems to be coming only from Anthem.
That's correct.
Given the desire we have to expand the treatment community so we have more people, we are at 60% or below capacity at this point, and we're now going to turn a bunch of other people away from providing this work.
I don't know if we're allowed to respond, but I think that's true of all of the rays, because that's true in Colorado Springs too.
They're also proposing to reduce the fees in the Springs as well?
Yes. So Ray 6 and 7, it's
Yeah.
like, I think it's statewide, which means, and I'm testifying later today, but my name is Dr. Renee Del Croce, but it's going to cause a great deal of issues with how practices are run, because groups are going to be about $9 now, and OBH wants a 2-hour group. And so it's like 1984 when I was an addiction counselor, I got $10 a group. And so it's like going backwards to me. I'm not sure how we're able to maintain a practice. So I'm just agreeing with you. And I don't know.
Hey y'all, so this is Summer. I'm gonna jump in just because the purpose of our conversation today is to definitely hear your concerns and your experiences and your stories. So appreciate that. We won't get into the debates right now. So I'm gonna keep us moving forward.
Okay.
But I appreciate you, Joyce, bringing this to our attention.
Okay, thank you.
Yeah, thank you. I'm going to check back in and see if Renee Yolande Allen has rejoined us by phone.
Yeah, can you hear me on phone?
Ah, yes, now you sound great, Renee.
Okay, right. Well, actually, I had the similar comments to make regarding what Ms. Smith just spoke of. And while I understand that sounds like this is something that you're tabling for now, I think it's also important to reflect that Medicaid providers have not been given a cost of living increase in the over 15 years that I've participated. So while maybe this current rate is too high, I think they can adjust it to accommodate the workload that it takes, as well as the expertise that it takes to work with diverse populations.
Got it. Thanks, Renee. That's helpful information to have. Is there anything else that you wanted to share today?
I would just say that the credentialing process is pretty arduous for new people to become paneled, which is part of the solution, is to get more providers, and it can take up to 6 months or more if things go bumpy for, again, seasoned providers to get paneled with Medicaid and the assorted raise. So I think that also needs to be addressed.
Great. Thank you.
Thank you for the time.
Absolutely. I want to check back in the room and see if Elizabeth Shear has joined us for in-person testimony.
Elizabeth has not joined us, but the next three people after her have. Do you want to just move forward?
Yeah, that would be great. So it sounds like Catherine Garner is next.
That's fine. I'm not shy. For those that know me. I actually wrote something down though. So for those that know me, that's also different. So I'm Katie Garner. I'm the Mental Health and Crisis Coordinator with District 51. So I guess I'll just jump right in. Where do I begin? As a professional, I've worked with students and on some occasions with adults throughout my 10 years as a mental health professional. I've worked in 2 states, including rural communities and urban communities. I grew up in Colorado Springs, and I was no stranger to suicide and mental health before graduating in 2003. Don't judge me for that. In fact, I lost 3 friends to suicide in high school. Maybe that's why I've chosen to help people struggling with mental health as a career. When I arrived in Grand Junction in 2016 as a school counselor, I was greeted with what we have dubbed the school year from hell. During the 2016 school year, I watched numerous students lose their fight with mental health. I watched a community break. I watched a staff put on a brave face for their students, and I watched kids suffer losses that they should never have to experience. After the 2016-17 school year, I started working with the community collectively to bring in resources together. We wanted to work smarter, not harder, and help our district make a structure to support staff and students in crisis. For the past 3 years, I've been continuing this work, and I've seen a lot of positive changes. We're working more collectively as a community, we're looking at trends and data, and we're working to break the stigma around mental health. But with all of these changes, I've also seen a lot of things remain stagnant. I have experienced a lack of communication from our local mental health agencies. I have experienced outlandish waiting times for students in crisis, and I have seen parents beg for help and feel like they have no choice but to go home and accept the status quo. Just yesterday, I worked with a local mother of a 10-year-old. He is diagnosed with ODD, major depressive disorder, and ADHD. He has an interest in weapons, gets physical with staff and his mother, and has made numerous threats. His mother cried to me that she doesn't know how to help him be safe, and she just wants help and doesn't want her son to become the next Columbine shooter, her words. The student had just been released Thursday after a 7-day inpatient with West Springs Hospital with a safety plan that only consisted of deep breathing for his tools. Within 3 days of release from inpatient, the student was escalating in behavior and was again placed in inpatient in West Springs yesterday. The mother didn't want him to go back because she felt they didn't help. They didn't provide her with any tools, they didn't give her any follow-up appointments, and they sent her home with one of the worst safety plans I've honestly seen as a professional. But what choice does she have? She works, she has other kids, and can't safely transport her child to the Front Range. Just last week, I had a teacher who works with students with severe behavior needs at her breaking point. Her school counselor has assessed this student for suicidal ideation every day for the past 2 weeks, sometimes multiple times a day. She had reached out for help from crisis services and they safety planned him out. This child needs support outside of her education level and outside of what the school can provide. She is at her breaking point because the majority of the day consists of therapy and therapeutic processes for not only this student, but for all of our students. She is not a licensed clinician. She is not a school counselor. She is a special education teacher who is taking on the burden of her students' clinical needs because she has no other choice. Anytime she reaches out for community support, she feels she is met with nothing. Many people will say that the shift of care happened with the shift of crisis services from Mine Springs to Rocky Mountain Health Plan. But the reality is we've always had a problem. We've always had a lack of inpatient services. We've had a lack of quality crisis services and a lack of providers. This is not a new problem. The problem just changed ownership, structure, and appearance. We have honestly taken a bad situation and wrapped it in a new package, but the problem remains. Colorado is the leader in so many arenas, and that's why I love living here. But we are honestly failing our people when it comes to mental health. We need a long-term, sustainable approach to mental health. We need to help people in communities recognize that mental health is common and it's actually okay to seek treatment. We need to provide our community with mental health providers that they can trust, their most important treasures with. In all honesty, every day we are letting our kids down. We are doing them an injustice by making them wait for help, safety planning them out, and providing them inpatient and crisis services that are not helping. Mesa County and Colorado need to become the leaders and trendsetters in mental health. And in order to do this, changes in funding and restructuring of services need to occur. We need affordable, sustainable access to quality mental health statewide, regardless of region or population. We need to properly compensate mental health professionals, not only monetarily, but emotionally as well, for the hard work they are completing on a daily basis. We need to recognize that we have mental health professionals burning out at a high rate statewide. Shifting, and this in turn shifts the burden to non-mental health professionals, including teachers, police, administrators, and more. We need to collectively see what is working in other communities and what can be duplicated statewide. We have to start having those tough conversations and truly understand that we have one of the highest suicide rates in the country and that the #1 cause of death for students in Colorado aged 10 to 24 is suicide. We need to stop hiding from these issues and we need to stop living in the past. We can't continue to point out the problems. We all definitely know what the problems are. What we need to do is start finding solutions for providers, families, community members, and all residents in Colorado. And the greatest lesson I've honestly ever learned comes from my mom, and she said that lessons are expensive. And the reality is that it's not always money. And right now we're learning lessons at a rapid rate, but it's in the form of lives. And at what point are we going to start taking those lessons and actually coming up with solutions?
Go ahead, Joya. Thanks for joining us today.
Well, thank you for inviting me. My name is Joya de Pasquale. I am a parent and a grandparent. I have had exposures to both mental health organizations and the DHS. I believe that we are failing in a grand form, our society. And it's not the person per se, it's the whole system. We have become a pill system, and so anything you have, they give a pill to. When I had my granddaughter or my daughter in Mine Springs, I'm going to discuss Mine Springs with you. Dr. Burson was excellent. He did whatever he could. I saw that he was totally overwhelmed with patients and what have you. I had the privilege that he took more time with me, I should say with my granddaughter. But every week, my granddaughter had a meeting with a therapist, and they changed every week. Now, I have a degree in psychology. I know that it's supposed to be bonding. You're supposed to bond with the person who you're giving your most intimate thoughts about. That doesn't occur every week because there is such a need for good for good people. It's changed. So my granddaughter would go in and she would discuss what her problems were, or she would try to discuss what her problems were. The following week, there was a different person there. The following week, there was still another person there. And this is very unfair to a child. Now, I've been in therapy. That was my God. That was that was the man that I told everything to. She didn't have that opportunity. She didn't have that blessing to do that. Because every week it was somebody new. And I brought it up a few times and I said, hey, what are we doing here? This is supposed to be patient and therapist. She's not going to bond with anybody. They brushed me off. And I could see the other side of the story. More people were coming in than they could handle. So it was a changeover and a changeover and a changeover. But that's not good. It doesn't work. The system is not working. That does not work. And now we have the social services. They come in, police can't go into the houses. Firemen, unless there's a fireman, can't go into the houses. Sheriffs can't go into the houses. They can come in and do what they want to do. It is imperative that they have somebody on their staff who is a psychologist. I have dealt with kids that just right out of there, they're 2 years and they know it all. Well, they don't know it all. They don't know it all, and they're not connected with the children. They're not connected with the adults. We must have someone in place in the social system who is a therapist, who can then oversee what's going on the way they do in Mind Springs, so to speak, to see what's going on in the therapeutic world, and not just give them a number, give them a pill or something like that. It doesn't work. Or have them come to the house. I had them come to the house. For what? Let's say I was a bad parent. I could have fixed everything up knowing that they were coming to the house that day, and then it could have been a mess after that. So this is where we're going. The same thing with Mind Springs. I sat in for a lot of the sessions, and then when I felt it was safe to not step into the sessions, I allowed my granddaughter to have her privacy, which I think is very important. I can go on and on and on and on about my own children. I have 2 adopted children. One biologically was born with, what would you call it? I guess bipolar situation. So I'm very familiar with this, with the institutions. There again, I had a situation that I have spent a lot of money sending my grandchildren to my grandchildren, excuse me, my child to different mental institutions at prohibitively expensive prices. It's a waste of money. I don't know what can be done, how it can be done. I don't have any, I can only speak from my own experience that it's all failing. There's no magic button, there's no magic pill. I think it has to be reestablished, the entire system, in a way where there are responsible people. We do not have a good system in place. I had to go get my granddaughter who suffered a breakdown just 3 weeks ago. She wasn't happy with her mother. She wasn't being treated properly. I'm in Colorado, she's in Missouri, and it's just something you feel that's not right. And then I get a call that she's in a mental institution. I got on a phone, on the plane, and I got into the hospital as soon as I could. And we're going to keep her another few days. And I said, fine, I'm going to bring her back to Colorado. I think Colorado has very good intentions. We lived in Vegas. There was nothing there, nothing. You want to talk about bad, no doctors, no therapists. I went to see a therapist with Ayla, and you know the Silver Book, the famous Silver Book that tells you everything that's wrong with you, was sitting on that desk. And I'm talking to this, I'm pretty sophisticated in this, and I'm looking at her, and I mentioned something, and she goes right to the book, and she starts looking up what I'm saying. Now, it's not her fault. She should never have been in that place. She should never, ever, ever have been there. I don't know what doctor put her there. I don't know what company put her there. I don't know what association put her there. But if she has to go to the famous Silver Book to look up what I'm talking about, she can't help people. So I don't know where to begin. I don't know where to end. I just know it's not working. And I have been dealing with this a very long time. One, my adopted daughter.
Joy, you have about 30 seconds. I just want to give you the heads up.
Well, God bless you all. I hope you find a place and a way of doing things. I'm done.
Thank you. Thank you so much for sharing your experience. Kevin Barclay is up next.
Hi, my name's Kevin Barclay. And those of people that have seen me talk before know I am no stranger to a crowd. The first time in my pretty nervous. So what I really want to get the message out is that men need to peel off the mask and share what's happening with them. We need to find a way to create better connectivity within our community. I am the president of NAMI, National Alliance of Mental Illness, and a lot of people question why was I involved. And I always had a pithy little response prepared, but I didn't really share who I was and what happened. I was 7 years old when the beatings began. I only know that because my sister remembers it vividly. My father used to beat the crap out of us. My mother used to watch. And when my father passed away one night, I remember we were relieved, my brother and I. And then my mother, 2 years later, was admitted to a mental health facility. So for 28 years, she was in there. And she died in the system. And sorry, not accustomed to talking like this, but in 1976, I suffered what was called a psychotic break. I was on an M1 hold for 3 days. They medicated me with lithium carbonate and Prolixin. I remember it just like the other day. And I had 4-point restraints and 4-point carries. Because of my size, they were scared of me all the time, constantly talking about how we got to control this guy any way we can. I broke out several times, started fights all around town, and created a lot of mayhem. The after effect was I met with a psychiatrist, alcohol, and he prescribed heavy doses of the same. That carried on. I was 6'9", 187 pounds. Great diet program, by the way, but you know. They over-medicated me because of my size, and they were afraid of me. And I was told this afterwards. The psychiatrist that I was working with was going to commit me to Camarillo State Hospital, which was a place in Central California. I walked to his office one day, I showed him the pills and I threw them in his trash. I said, this stops here. I don't even know where that came from. I don't know how I am today. But 2 things I want to get across. Some people ask, why am I involved with the Army? And I come up with this little program to destigmatize conversation. I've been a fraud for years. I volunteered in the system for years, trying to help destigmatize conversation and help build better connection. And I did it under the bravado of, hey, I'm 6'7" Kevin, blah, 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 blah. You know, I feel like 5'7" Kevin. Month and a half ago, I was in a really dark place, and I'm still kind of there. And I don't reach out because I don't feel like I have the ability to do that. And Jill's the one that talked me into saying my story because I want to get more peers involved. I want to have more people. I want to really encourage men to share their story. It's not like this, I mean, but it comes out how it comes out. I had something really different planned for this because I'm more of a comedian than I am this. But sitting next to Jill Dario, who encouraged me to share my true story, she thought it would be great for other people to see the story and hear the story, so maybe they could come out also. The only way we solve the problem that we have in Mesa County is to create better connection. I've been talking about that for years now. And I think one way to do it is get men talking, you know, and find a way to rip off the masks and let people know who you are, and not have some teary rendition in front of people, but whatever it takes. I'm willing to put myself out there. I want people to know, I want other men to know, you know, I just want to bear it all. I want people to know that there is a way, and it's through connection. It's going to take a village to solve this problem. We have wonderful practitioners and people that work in our community that are overloaded. They're stressed out. As a life coach, I've seen many of them in my office saying, I can't take it anymore. I talked to the lady today that works with children. She was working with them and couldn't believe that she could work 24 hours a day if she wanted to. We need the village. We need the encouragement. We need the connectivity. We need people to be able to talk to one another. At NAMI, one of the things we're working on is connection support groups, peer support groups, and other things. And I just want to encourage those that see this and you have an issue. I encourage all of us to take the mask off and connect with someone. And the call to action that I'm putting out to people also is reach out to somebody once a day, just in a real way. And if it's challenging, you can do it any way you want. But there's so many hurting people out there, and I get to see them. And I just, you know, we have a beautiful town. We have beautiful people to support the Western Colorado Foundation and District 51 and partners and all the beautiful people we have around. But it takes a village. It's going to take the peer group. It's going to be the big guys in the world. We got to stand up, and we got to recognize, you know what, we've got some issues. Nobody's bulletproof in this. Mental health reaches us all. And I'm sorry I've been such a fraud over the years. But I think it's so important for me to put my story out there so people can see that it's a real deal. And driving off a monument sometimes it's an option that you think about. I never thought I'd be that guy, but and I certainly didn't think I'd be talking like this, especially some of you that know me. Anyway, that's my point. I'm sticking to it. And at NAMI, the wonderful people that can contribute have lived experiences that are so real and vibrant. You know, the knowledge that we have is because we've been there, done that. The connection that I have is I understand where people are coming from. When they say they want to drive out the monument, I got that. And you know what? People don't mind talking to peers. And for you men out there that are listening to this, please connect with one another. We don't do coffee classes, but we sure can sit around a beer. There's got to be something that's counterintuitive, sorry, but there's got to be something we can do to do a better job of connecting. And that's what I want to encourage. So forgive my, I don't think it gets any more raw than that, right? Anyway, am I up with
Kevin,
yes.
Thank you. Thank you for just being courageous and taking the mask off and sharing your experience. It's important for us to hear. It's important for other men to hear, and just will help us make things better. And thank you for the important work that you're doing with NAMI. That's really key.
Thanks. I don't know who I'm waving at, but yeah. Thanks.
I think you connected with a lot of us.
Yeah.
Thank you.
Looks like the next person is Andrea Thomas, if she's in the room.
Okay.
Hi, my name is Andrea Thomas. I'm with Voices for Awareness. This is Deanne Hopkins. She's also in attendance. She's our co-director. Voices brings our awareness to the issues of substance misuse, substance abuse, counterfeit drugs, self-harm, and suicide prevention, and the stigma related to all. Most of you are probably aware that all of these issues are an epidemic in our valley. Our schools are teaching sex education, and we have controversial bills underway in Colorado to address the issues of abortion and even LGBTQ relationships within those sex education classes. But we are not addressing the epidemics at hand related to substance abuse or prevention. Our youth needs to be educated to aid in prevention of self-harm and substance abuse. Gone are the days of the DARE programs and just say no to drugs in our schools. Why? This is the worst time in history for our youth as far as drugs and suicide go. Illicit drugs and self-harm are prevalent in our schools. These are critical issues that we need to address in school. Coping skills are missing for a great majority of our children. Voices feels that education is key to prevention. According to the National Association of School Psychologists, mentally healthy children are more successful in school and life. Good mental health is critical to children's success in school and life. Research demonstrates that students who receive social, emotional, and mental health support achieve better academically. School climate, classroom behavior, on-task learning, and student sense of correctedness and well-being all improve, as well as mental health. Mental health is simply not the absence of mental illness, but also encompasses social, emotional, and behavioral health and the ability to cope with life's challenges. Left unmet, mental health problems are linked to costly negative outcomes, such as academic and behavioral problems, dropping out, and delinquency. There is a growing and unmet need for mental health services for children and youth. According to the U.S. Department of Health and Human Services, 1 in 5 children and adolescents experience a mental health problem during their school years. Examples include stress, anxiety, bullying, family problems, depression, a learning disability, and alcohol and substance abuse. Serious mental health problems such as self-injurious behaviors and suicide are on the rise, particularly among youth. Unfortunately, estimates of up to 60% of students do not receive the treatment they need due to stigma and lack of access of services. Of those who do get help, nearly 2/3 do so only in school. Schools are an ideal place to provide mental health services to children and youth. Virtually every community has a school, and most children spend at least 6 hours a day there. Schools offer an ideal context for prevention, intervention, positive development, and regular communication between school and families. School-employed professionals like school psychologists, school counselors, school social workers, and school nurses know the students, parents, and other staff, which contributes to accessibility of services. In fact, research has shown that students are more likely to seek counseling when services are available in schools. In some cases, such as rural areas, schools provide the only mental health services in the community. School mental health services support the mission and purpose of schools, which is learning. All services provided in schools should be appropriate to the learning environment. Those that are not risk being ineffective or even counterproductive. Just as children are simply not small adults, schools are not merely private clinics and chalkboards. Being trained to work within the culture is essential to bring effectiveness and cost-effective. School mental health services are essential to creating and sustaining safe schools. Increased access to mental health services and supports in schools is vital to improving the physical and psychological safety of our students in schools, as well as academic performance and problem-solving skills. School mental health supports that encompass social, emotional learning, mental wellness, resilience, and positive connections between students and adults are essential to creating a school culture in which students feel safe and empowered to report safety concerns, which is proven to be among the most effective safety strategies. Additionally, in the aftermath of a crisis, school-employed mental health professionals provide supports that facilitate to return to normalcy and are sustainable and can help to identify and work with students with more intense or ongoing needs. In closing, in our endeavors to bring awareness, we attend conferences and seminars about self-harm and substance abuse, and we always inquire, where are our youth? The explanation is that these subjects are too explicit for our youth. How can that be the answer when we have kids overdosing and dying from suicide all over our state? There are a multitude of programs that can be initiated in our schools at little or no cost. Shatterproof, the SAFE Project, Alateen, even the DARE program is still out there. Voices for Awareness respectfully ask that you please consider bringing awareness to these epidemics in our schools. Mental wellness basics and a mental health foundation is crucial to our youth and to their futures. And that's all I have.
Thank you, Andrea. I think we'll be sure to share that with our children's subcommittee. It'll be important for them to hear.
Hi, I'm Michelle Hoy. I have the pleasure of being the Executive Vice President of Mind Springs Health, which is one of the 17 community mental health centers in Colorado. And there's so much to say and not enough to say about mental health in Colorado. What I can tell you is that every single day, I 100% feel, hear, and am told about the frustrations and the lack of resources in our state. The frustrations from everyone, family, friends, and loved ones, to partners in law enforcement and hospitals and schools, to government officials, to our clients who are in the lobby, who are saying, we need more, we need more. And I also know, with no doubt at all, that every single day, my teams save lives and help people get better. And I think this is the dissonance that is really difficult to manage and understand, which is that we truly don't have a system that makes sense. Sometimes I feel like as behavioral health providers and administrators, we almost make the system too simple to navigate, because I think many people don't have an understanding of the extreme complications behind the scenes. When people walk through our doors, we serve them. We don't bother those folks with trying to figure out what bucket of money to pull from, because there's probably about 300 choices that me and my staff have to find a way to put people into one of those buckets to get the right dollars to do just the work. And again, I think it's this dissonance that on one hand, we do things in a very seamless way, given how complicated it is. And on the other hand, it's extremely complicated because not everyone gets everything that they need. And I believe there's a real mismatch in our state around expectations of communities and partners and people who are experiencing mental health and substance use crises, as well as just seeking help, and the system and the funding. The lack of funding, I think, in the state has really mismatched expectations and what we can truly accomplish. I think we've patchwork quilted together to the very, very best of our ability. And we do awfully good work. And unfortunately, it's not something that can be counted on every single day by every single person. I also think that as I'm out there in 10 different communities on a regular basis in Western Colorado, that when we talk about mental health, I would guess if we took the time to poll people and ask, what are you talking about? We'd all be talking about completely different things. It could be anything from a temper tantrum to a psychotic break to somebody who's drunk in the park. These are all vastly, vastly different scenarios. And when you put everything under the umbrella of mental health, I think it's easy to get lost. I think one of the things I am hopeful to say and share is that my true hope for the task force and others is to think about how we take existing systems of care that are truly giving their blood, sweat, and tears and doing their absolute best to do the right thing and pull them together instead of tearing what little system is there apart in the name of redoing the system. I think that we need to really consider how to bring together the multiple pieces. It even just struck me as I've been sitting here today that I know that the school district here has a prevention curriculum. And I would guess most people don't know that. And again, it's probably not enough, but lots and lots of things happen that people just don't realize or know about. So my hope is that we stop blaming and distrusting each other, and that we take this opportunity to pull together and think about what is working. How do we replicate that more? How do we understand better what's actually out there? And how do we create a system where it's not about siloed funding and placing people in buckets? People come as people, which is one big mess. That's all of us, including myself, right? I have family who have mental health issues, and I think all of us do. I want all of the people I care about to get the help they need. I know everyone else does. I think the question is how we take this complicated system and simplify it and not tear it apart, because that will hurt vulnerable people. And I think that that's one of the things that really scares me when I think about transformations that have happened in other communities, is how do we really assure that the most vulnerable people aren't hurt and left behind by change. I also believe that this is truly a community issue, and that there is no sector that's left out. I think that's part of what's loud and clear. It also means that there's not enough therapists or doctors in the world to fix this. I 100% believe in the power of helping touches. A postcard can be helpful when it comes in the right place at the right time. A happy smile on the other end of a phone who just says, hey, how are you today? It can be helpful. We don't have to medicalize this entire thing. We can be much more creative than that. And not everything that is good for a person's mental health is necessarily a therapeutic service or should be one. It's got to be a community issue that I think every community has to really get behind and invest in. So yeah.
Michelle, you have about 30 seconds.
Okay. Yeah, I think overall, let's pull together instead of distrusting and think of ways to simplify. Thanks.
Thank you for being here. Good job.
Summer, will you just give me 30 seconds? I need to switch phones.
Sure.
Okay, whenever you're ready, go ahead.
Okay. Well, my name's Terrence Lawrence, and I'm a recovering addict, alcoholic of many flavors. I've had a lifetime of sharing my story because it's an important part of my recovery journey and process in healing and wholeness. So I'm familiar to share my story today. However, I must say the greatest challenge for me is to be able to keep it in 5 to 8 minutes, because I'm actually been asked to write a book on it several times. But I'll summarize this to the best of my ability. Who I am started, and the results of my addiction started in my childhood. In my childhood, I was raised in an alcoholic home by parents that were active alcoholics and drug addicts. And I was exposed to a lot of violence in the home at a young age. And I was taken out of the home repeatedly for my own safety by various social service agencies and placed in foster homes, boarding schools, and orphanages over many, many years. During that time, I was physically abused and sexually abused in some of those homes. I've been diagnosed with chronic PTSD, and I suffered for many years from rejection because of the abuse of my childhood. Tremendous anxiety disorders. And so from those early childhood experiences, I kind of developed the core of who I became later in life, both on the negative side in relationship to my addictive behaviors, but also some of the criminal behaviors that I exhibited occasionally in my lifetime of battling addictions and overcoming what I had to go through in my childhood. So I'm going to share some of that as briefly as I can in a summary of what happened, what I went through, what worked, what didn't work, and how I see my life today in respect to some of the lessons learned in my life journey and recovery. So at the age of 14, 15, I tried to overdose on pills for the first time. And I spent 2 weeks in a mental health institution for the first time. After that, it came to light of the sexual abuse and physical abuse I had suffered in many of the out-of-home placements I was placed in as a child. So in that, they started giving me psychiatric care and treatment with psychiatrists, psychotherapists. I was in treatment centers off and on from 14 to 16 years old. I began attending Alcoholics Anonymous as a young child at the age of 15. Then in the 1980s, after joining the Army to try to get off the streets of a back east city that I grew up in, Boston, it saved my life by joining the military because it gave me some things outside of the lifestyle of pain and addiction that I was getting quickly adapted to in criminal lifestyle. So I moved elsewhere outside of where I grew up. And I did okay for occasional bouts with addiction with alcohol primarily in my 20s. I achieved 5 years sobriety when I was in my 20s in Denver by going to AA mainly. I also went through adult ACA, it's called the Adult Child of Alcoholics, which for me at that time actually stirred up more because I didn't have a strong treatment-based presence in my life. So it stirred up more stuff from my childhood than I could deal with. And it kind of led me back into relapse mode. I've got a lifetime of building my life up successfully in business, in family, and in the community, and occasionally tearing it all back down again because I relapse into what will help me feel better, or change the way I feel, which is addictions or addictive behaviors of different types. I came out here to Grand Junction, Colorado in 1991, went through a 4-month program called the Addiction Resource Unit, and I began an 18-year period of sobriety here in Grand Junction, Colorado, during which time I built a wonderful family, a wonderful, huge business, and I became very successful in the community, and I was actually doing a lot of community work, both here and around the world. And then when the real estate construction market started falling apart in 09, 010, there were relationships in my life that started disintegrating along with the business failures. And I had a lot of hidden issues deep down inside of me that still hadn't been addressed because of my childhood. And I'm not using that as an excuse, but it was part of the process that led me back to actively using again and picking up more addictive behaviors than I had before, with gambling, with work, with even religion at one point. I just was becoming obsessive compulsive in several areas of my life to overcome the pain and the shame of my childhood. So I relapsed for about 4 more years. During that time, the A&E television program did my story on interventions back in February 2012. As a result of that, they put me through some very expensive, high-profile, nice treatment centers. I went through a couple of them. I still was not able to overcome and maintain long-term sobriety in that, and mainly because of the amount of losses emotionally and physically I was enduring as a result of the business failures. So I ended up relapsing again, and then finally got in trouble with the local law enforcement because of drugs. And I got a 5-year sentence for drug sales in 2013. and I did 4 years of a 5-year community corrections-based sentence. So I've been through the criminal justice program in Western Colorado. I've also been through their treatment programs as well. So having said all that, what has worked in my life and what hasn't? And I'll try to be brief and summarize this. I'm not sure of the time yet, but.
You have about a minute left, Terry.
Oh, wonderful. Okay. Well, here's what's helped is being able to have a comprehensive, strong community-based support system that helped me change my belief system and my identity into long-term believing that I was worthwhile saving and that I was worthwhile by changing and becoming productive again in my life in recovery. I utilized various treatments of everything from EMDR, somatic experiences, psychotherapy, strong AA and NA membership in 12-step groups. I had small men's groups that held me accountable weekly, and I went to church every week, and then I had a strong daily and weekly spiritual program. I attacked recovery and sobriety on an emotional, a physical, and a spiritual realm because I had to, all three, or I wouldn't have survived. Today, I have almost 7 years sobriety successfully. I have rebuilt the business I never thought I'd be in again. I have a new family, and I am a certified recovery life coach, helping many, many other people on this journey get through the many levels of healing, current and past traumas that I survived from. Today, it's about how I can impact others and help others in their recovery journey, to help them understand that they need to remember and practice daily to be intentional and purposeful in their own individual recovery. And to the extent that I am determined to be honest and free of the things of my past, accept my true identity of what my real strengths and weaknesses are in my life, accept what I can and cannot change, then I can truly live in wholeness, healing, peace, and freedom. Thank you.
Good. All right. Good afternoon. My name is Timothy C. MacArthur, and I'm a licensed social worker with the great state of Colorado. I'm originally from the Front Range, but I'm proud to call the Western Slope home now. And for all the problems that I saw that we faced in the metro area, the Western Slope definitely has its own. Just in Mesa County alone, we have much higher rates of suicide, depression, and poverty than the rest of the state. In my work, every day I see the challenges faced by the lack of resources in our community. And I can't tell you how often I assess clients and I can determine exactly what the problem is. However, the appropriate treatment for that problem is either not available or there's no funding available for it. 23 years ago, it was established that mental health treatment should receive parity with medical treatment. As we stand here in the future of 2019, that utopian future that those in the past envisioned is far from being realized. Mental health care remains drastically underfunded and under-resourced. Just as Terry's story illustrated, in 1998, the Adverse Childhood Experiences Study funded by Kaiser Permanente revealed to us that trauma impacts not only our mental health, but also our physical health as well. This study changed our perspective and showed us that issues like obesity, heart disease, and drug abuse were all related to these early traumatic events. This was revolutionary at the time, and yet how many people to this day have ever even heard of this concept? How many people are currently aware that these issues are not moral failings, they are societal failings? When we as a society allow these issues to go untreated, we all suffer as well. If someone goes to the doctor with chronic headaches and the doctor finds out the reason the patient keeps getting these headaches is because the patient is suffering from a brain tumor, it would be considered malpractice for the doctor to just send the patient away with some Tylenol. The doctor realizes that the pain is only a symptom of the disease and prescribes a treatment to address the root cause of the pain. When we as a society incarcerate people with mental health and substance abuse issues, we are treating the symptom of the disease and not the cause. And worse, we are re-traumatizing already highly traumatized individuals. This does not fix the problem, it only makes it worse. We know this, and yet we keep doing it. We keep expanding jails and building new prisons. Somehow we always have the budget for that. But for some reason, we just can't find the money to provide people with the mental health treatment they so desperately need. We get caught up in petty squabbles about budgets and fiscal responsibility, but do you know how much it costs to incarcerate someone? And if you put someone in jail or prison and don't provide them with any treatment while they're there, what happens when they get out? Think of the long-term costs here. This starts so early. I heard a lot about the school to prison pipeline when I was in grad school, and now I see it firsthand. We take kids that are acting out, and instead of trying to determine the root cause of their behavior, we shame them and we ostracize them. We call them out instead of calling them in. We suspend them and then expel them, and what happens after that is none of our concern. We do this all in the name of school safety, but how does this make our communities any safer? We take a kid who is exhibiting problematic behavior, and instead of trying to determine the root cause of the behavior, we show them that they are bad and they do not belong, and we kick them out. How does that fix anything? More than likely, the kid is probably acting out because of problems he or she is dealing with at home. But does anyone ask about that? Does anyone ask why? Instead of trying to dominate and discipline kids, maybe we should listen to them. What the schools could have addressed and treated early on now gets passed on the criminal justice system. And that definitely doesn't save anyone money. This is just a quick 5-minute synopsis of the problems I see on a daily basis. If you want my recommendation, it's twofold. Number one, true parity of mental health treatment with medical treatment and criminal justice funding. Number two, redirect our attention and resources upstream to catch problems earlier rather than later. The sooner you catch it and treat it, the less damage it causes to society and the more money it saves all of us taxpayers. Thank you so much for convening this task force and allowing me to speak before you today.
Thank you, Timothy. That was great. Appreciate the recommendations. Want to do a room check and see, are we ready to keep going, or do you folks need a quick break?
We don't have anybody else in the room left to testify. There's one more person we're waiting on at 2:30, and then the other two are Zoom. Do you want to see if either of the Zoom people are here?
Sure. Joni Palin, if you're joining us by phone or by Zoom, please unmute yourself. If you're joining by phone, you can unmute yourself by hitting *6.
I should clarify, we do have two people later on in the day at 3:40 and 3:50 as well.
That are in the room?
No.
Okay.
It might be a good time to take a little break since we've been going. Is everyone all right to take a 10-minute break? And we'll see if more people join us. Is that okay with you, Summer?
That works great. We will resume at 2:30.
So I'm Mari Hibbard. I'm a social worker at St. Mary's in the emergency department. I've been there 11 years. I primarily do psychiatric evaluations there. So I wasn't going to speak. I don't have anything really prepared, but Michelle Hoy convinced me. I would like to echo Michelle's comments in that I think transformation makes all of us nervous and excited at the same time. We know that there needs to be changes to the mental health system that we have here in Colorado. I also would hope that those of us that are doing this type of work every single day and have been for many, many years can be involved in any changes that are made. I think when systems change, oftentimes it feels like those of us doing the work are left out of the mix, and rules or policies are imposed that makes no sense for the type of work that we do and the types of collaborations we do have and the parts of the system that do work well, which isn't all of it by any means, but there are things that work. We have a pretty solid community in Mesa County with collaborations, with teams, with people that come together to accomplish difficult tasks, to staff individual patients, to come up with individualized plans that can help a member that's struggling, that all of us are at loss as to how to help. So yeah, and I also want to comment what Michelle said about don't medicalize this too much, because human connection and communities and upstream thinking, all of those things can help, oftentimes much more than all the stuff we have to do after the fact to deal with trauma versus prevent trauma in the first place. So as much as we can focus on upstream interventions, community partnerships, relationships, human connection, and involving those of us, doing the groundwork every single day to improve the system, to make it better, but to make sure that we're still working together and not bringing in outside agencies. We've had a recent very big shift in the mental health system here. And Michelle and I were just talking on the break. The ER has been impacted. We've seen a huge number of patients now coming to the ER that weren't coming prior, which of course is the most expensive place to get care. But we've also seen a huge number of people not getting help at all because they feel like the system's broken. They don't understand how to access services. They have fear surrounding the change, and so they're just not getting care at all, which I think is much more worrisome than utilizing the old system and building in supports to make that better, instead of what we've done is this complete shift where clients get all sorts of different answers. They call the recommended hotline. I had an officer last night that was told, oh, drive to Montrose, that's where you can get help. The model's supposed to be, you know, there's a mobile evaluation available, but that's not the message that clients are getting when they call the state hotline. So yeah, I would hope that before we change it all up again, think about what's working and add structure to that versus undoing. Those are my comments. Thank you.
Thank you. Appreciate that. Mike.
Thank you. I want to check in to make sure that Maggie hasn't shown up.
No.
Okay. Let me check in and see if Joni Palin is joining us by Zoom or by phone.
By Zoom.
Great. We can hear you loud and clear. Thank you.
Yay!
Thanks, Joni, for joining us. If you want to share your testimony in about 5 or 6 minutes, that would be great.
Okay, great.
You can go. You're ready to go.
I'm ready
Sorry,
to go.
your time limit is 5 or 6 minutes. Sorry.
Oh, okay. So I am a psychotherapist in Conifer, and one of the reasons why I really wanted to get an opportunity to address the task force, which I appreciate, is primarily because of the CCHA plan to decrease the rate at which they reimburse people by 20%. And that I just feel is really, it's going to have such an impact on therapists and clients both. I mean, I'm a member of the Park County Mental Health Project, which was developed because Park County, which is part of CCHA, has such problems getting services to their clients. And so there's a lot of people that are falling through the cracks. And Governor Polis has, really said that he is committed to providing better mental health services to Coloradans. And because of him, we do have a budget to be able to investigate those things in Park County. I've taken Medicaid clients for about 3 years, and I don't know that people really know that we already take from CCHA about a 20% decrease in what our regular fee is, and this would make it another 20%, which would actually be 40%. And it makes it really difficult to keep the doors open, not just because of the reduced rate, but because there's also a pretty big no-show element to Medicaid clients that either don't show or, cancel at the last minute, which means, those are spots obviously that you can't fill. And, I hate kind of making it about money, because one of the reasons why I felt I wanted to take Medicaid is, as a social worker and as a marriage and family therapist, I feel it's kind of part of my job is to serve the underserved. So I hate the fact that this might be a change that either really seriously limits my ability to take Medicaid clients, or, might eventually make me just terminate the contract altogether, because it'll be too difficult to maintain. So I guess I would just urge you, if we have the capability, to get CCHA to rethink this rate cut, because I think it would have far-reaching ramifications. That's pretty much it.
Thank you, Joni. That's really great to understand. And I know a lot of people are bringing up the decreased rates with CCHA. What I will share is that I think it's helpful to bring this to the attention of the task force so that we can think about it going forward. And we really are looking at kind of the blueprint starting in July 2020. So I think these are things that we can take into consideration, not necessarily the task force can't necessarily address this right now.
Yeah. Okay.
But it's good information to have. So thank you.
Thank you.
Let me check in and see, we're a little ahead of schedule, but Tammy Bach, are you online by phone or by Zoom?
I am on the phone.
Oh, fantastic. Thank you for joining us, and thanks for being here early since we're ahead of schedule.
Oh, okay.
So feel free, Tammy, to go ahead and share your testimony. That would be great.
Sure. And so I'm just going to jump in right after you said, well, we can't really do anything about the CCHA decrease, because that's exactly what I was going to speak to, and I will. I've been a medicated provider for over 10 years. I'm a licensed professional counselor and a play therapist. I'm always trying to get new providers to come on board with Medicaid because Medicaid needs high quality providers. But with the pay decrease, that's nobody is interested. And because a big fear that providers have is the extra paperwork and the compliance issues that are trickier to navigate than other insurance companies or private pay. And so with the pay scale that it is right now, it's a little bit of a benefit and it attracts high quality providers, but you're not going to attract those providers without it. As a play therapist, I have turned away up to 20 Medicaid clients per week, and any referrals that I give them, they've already called. I have moms who call me in tears and leave a voicemail in tears saying, we really need to get our kid into therapy. I've been calling Medicaid providers for 7 weeks. I just found your name. Please, are you taking clients? And I can't take them. And when you decrease the rates, you're decreasing the ability for people to find quality services, if any services at all. It's already a shortage, and the rate decrease is going to make it a much bigger shortage. And that's it.
Thanks, Tammy. Definitely appreciate that. And certainly I think the task force needs to understand the implications of the rate decrease. So again, just appreciate everyone bringing that to our attention. So we are way ahead of schedule at this point. Robert, is Gwen Eller in the room by any chance?
Not yet.
Is there anyone in the room who would like to testify but hasn't signed up?
Nope.
Let me check online and by phone. I know earlier Renee, I'm not sure if I'm going to get this last name correct, Della Croce was with us. Renee, are you still with us?
I am.
Great. Are you comfortable sharing your testimony now since we're ahead of schedule?
I am.
Great, thank you.
I hope you can hear me okay.
You sound loud and clear on this end, so
Awesome.
Perfect.
So I've been a psychotherapist or in the counseling field for 30 some years. For 28, 29 of those years, I provided treatment for people that have Medicaid. And I've seen it go through a lot of changes. In 1984, when I was an addiction counselor, we charged $10. We got $10 a group. With the new rate decrease and the the Office of Behavioral Health expects addiction counselors to do 2-hour groups at a rate of when the changes go into effect, it will be $9 a client with a cap on 12 clients. which is about $100 some, I guess, for a provider if all 12 show up. And then you've got costs of your rent and your continuing education and cost to pay your providers. And basically you're paying, the rate decrease will put us at lower than minimum wage professional counselors. So I'm a PhD, I've been a licensed professional counselor for 15 years, an addiction counselor for many years. I work primarily with children in foster placement. The state of Colorado is planning on closing residential treatment facilities, which are not good places for kids to thrive and get healthy, and are hoping that they'll do license what's called step-down homes. And so the agency I work for, foster placement agency, is looking at providing increased therapeutic services for step-down homes for kids coming out of RCCs who are high-risk kids with addiction issues, mental health issues. They're at risk for runs. They have been sex trafficked. And what happens is when they come out of those residential treatment facilities, sometimes it's a month to 2 months before we can get them into a Medicaid approved provider. If we had our own providers here, we would be able to get them in sooner. But once again, it's trying to run a clinic that is comprehensive and that will, so you have lower caseloads so that you can do a better job and offer, more intensive services with assessments. It's more difficult to give quality service when you're trying to make a living. And I'm sorry that that's just a reality of the world, that we go to college to try to make a difference in the world, but we also need to make a living. And in order to make a good difference, we have to be able to get a pay rate that is competitive and that is comparable to provide the best service possible for clients. I want my clinicians to give assessments to the clients so that we get good diagnosis. I want them to give them individual sessions, group sessions weekly. And so I don't want them to have high caseloads because the clientele are high risk and demanding. But in order to make the clinic run on lower rates, you have to increase the caseload, which decreases the quality of care. And so I really want the task force to rethink how they're appropriating the money. I mean, I've worked in the system taking Medicaid for a long time at about a rate of $84 to $100 a session for many years. And so I don't think that we're asking for a great increase. I just think we're asking that it not decrease. And so I don't think that it was thought through the ramifications to the clients or the providers, and that many of my colleagues have closed their agencies and have given up taking Medicaid because of issues like this. Most kids that come out of placement who've been in placements like hospitals and residential treatment and group homes, been in there for years, and their needs are very high. And so in order to give them the comprehensive treatment that they deserve, so that they don't run away and so that they're not acting out and they're not doing drugs and they're not becoming more and more mentally ill, we need to have good providers. And in order to do that, we need to pay rates that are competitive with what psychotherapists should be making. So that's all I have to say, and hope that you just consider looking at more variables of, I understand that there's a budget and we need to meet the budget, but there are variables that is going to cause more costs for the state of Colorado if good treatment is not given to kids, at least in foster placement, or even anybody that's on Medicaid. I really think it's kind of sad that in 1984 we were paid $10 for an hour-and-a-half group. Now the Office of Behavioral Health mandates that we run 2-hour groups, and now we get $9 for 2 hours. I just hope that that's something you can consider. And that's what I have to say.
Thanks, Renee. That's really helpful, and appreciate all the details. So thank you.